I don't think I'll ever get tired of listening to those drums. Aren't they just fantastic? Welcome, everyone. My name is Vikash Shah, and I'm your host for this Friday live stream. How are you all doing today? It's the 7th of July, which means that if you're watching this with me right now live, that there are only 17 days left until the start of Radiopedia 2023. And if you're watching this on catch up, there are even fewer days remaining. Now, we don't actually have a physical Radiopedia headquarters because we're based all around the world and do most things online. But if there was a HQ, it would be an absolute hive of activity right now. So what's actually happening? Well, all the lectures have been polished up with premium video and audio treatment. Every single lecture has had English subtitles applied to them. Hundreds of review questions have been written. A bunch of panel discussions have taken place and are being edited. And the final R posters are being tweaked for presentation. But I want to tell you a little bit more about one other aspect of the conference, the workshops. Now, we've got 4 workshops this year. There's trauma imaging with Andrew Dixon and Craig Hacking. There is nuclear medicine with Sally Ayesa and David Little. There is neurovascular with Frank Gaylord and Peter Mitchell. And then finally, I'm doing one on renal imaging with Joe Molyneux. Now, in each one, you get to look at cases by yourself, which means actually be able to scroll through CT and MRI stacks by yourself and then be taught about those diseases by your workshop hosts. Now, the host will be in the chat box too, so you can actually directly ask them anything about that topic. And it's not surprising that the workshops are one of the most popular pieces of content that we produce, and it'll be the same this year. So trust me, you do not want to miss out. So please make sure you go ahead and register for the conference. And you know the drill by now. Free access in 125 low and middle income countries. The other options are to purchase a conference only ticket, or you can actually purchase an all access pass, which gives you access to the conference and a whole heap of other content. And remember that tiered and concession pricing rates are available. So let's get to today's lecture. This one is by none other than Miranda Shiminovich, a consultant in chest imaging in Melbourne in Australia. And this lecture is titled Pulmonary Fibrosis, an Imaging Survival Guide. Now, Miranda possesses something quite rare and special amongst educators, that ability to break down a really complex topic in a completely relatable way. And you'll finish this lecture feeling so much more confident about pulmonary fibrosis than when you started. So thank you, Miranda.
Hello and welcome to this talk where we're going to take everything that is known about fibrotic lung disease and distill it down to the essentials that you need to report these cases in day-to-day practice. My name is Miranda Sheminovich, and there's good news because there are only 3 disease entities that make up the majority of diagnoses in the general population, and these are usual interstitial pneumonia, hypersensitivity pneumonitis, and non-specific interstitial pneumonia. If you have an algorithm that can differentiate between these 3 entities, you will cover the vast majority of cases that are going to cross your desk. What we're also going to talk about today is what to do when the volume of disease is very small, what to call normal and dismiss, where to draw the line, and how to deal with those borderline cases. So usual interstitial pneumonia is the disease process that people tend to be the most comfortable with. It's the most common. We all know about this distribution that is peripheral and basal fibrosis. We see reticulation, we see traction bronchiectasis, and we may or may not see honeycombing. And this may or may not is important because it carries a strong prognostic implication. Patients with established honeycombing on HRCT have a dismal prognosis with a mean survival of often only in the order of 3 years. And applying this term carries a significant clinical weighting. So let's look at a case of typical usual interstitial pneumonia pattern fibrosis. So When we're interpreting fibrotic lung disease, we're doing a twofold assessment of both the morphological characteristics of the disease process and also the distribution. So we'll start with the morphology and we'll just scroll down through the whole case and have a look at what we're seeing. So we've got severe extent fibrosis, there is extensive abnormality, and this manifests as a combination of fine and coarse reticulation, where you see these abnormal linear markings throughout the periphery of the lung. We call this fine reticulation when the markings are closer than 4 millimeters together, coarse reticulation when they're further apart. And what we also see is extensive traction bronchiectasis, so these abnormal dilated airways. You shouldn't see any airways within the 1 to 2 centimeter of lung that's immediately deep to the pleura. So here again, beautiful traction bronchiectasis. Traction bronchiectasis because this is airway dilatation that's surrounded by abnormal lung, and typically also this irregular corrugated appearance to the airway walls. So reticulation, traction bronchiectasis, and in this case, extensive honeycombing. So honeycombing are these clustered subpleural cystic spaces that have shared walls and are up against the pleura. They are typically of a uniform size, one to another, with this sort of homogeneous size appearance, and they may be stacked back in layers like they are in this case. You don't need the layering to meet the criteria. In this case, quite extensive honeycombing. So in terms of the distribution of disease, the thing to focus on is this center core of the lung. So this kind of 1/3 of the parenchyma that's sitting in the real center of the lung, and just having a look as we scroll down the entire stack to assess how crisp and clean the bronchovascular structures are that pass through that center core. You can see that all the way down, coming down the right-hand side and then moving up on the left, all of those bronchovascular bundles are completely clean and they're surrounded by normal lungs. So this is the test to determine that this is a peripheral distribution disease. The other subtlety that I want to spend just a minute looking at before we move on from this case is also the way that UIP is typically scattered in its involvement of the lung parenchyma. So here we've got a little patch of normal lung that goes right up to the pleura, and then we've got some regions of abnormal lung. Here on the right-hand side, again, laterally, there's a bit of normal lung that gets out to the pleura. So there's this sort of patchy involvement. And also the degree of coarseness that we see in the involved lung is different from one region to another. So we've got areas here, so again, this sort of posterolaterally in the right upper lobe, we've got fine reticulation, but not much else. Whereas more medially in that same lobe, we've got the beginnings of this traction bronchiectasis, and anteriorly we have frank honeycombing. So that kind of heterogeneity of coarseness is typical for UIP. So severe extent UIP. We'll just have another look at the same kind of pattern of disease here with another case of UIP fibrosis with a relatively severe extent of involvement. So again, we're looking at the center core of the lung in the distribution, and we're seeing how clean that is. Morphological features, again, are this fine reticulation, as extensive honeycombing as you come all the way down into the costophrenic angles, but a lot less in the way of traction bronchiectasis. So here's a little fine dilated abnormal airway, but the mix of these different features of fibrosis is going to vary from patient to patient. Now, that basal predominance is really well seen when we look in the costophrenic angles. So really, this is your money shot here as you scroll right down to the lung bases. You really want to see in UIP pattern fibrosis those costophrenic angles completely filled. So you do always scroll right down to see those very last slices to prove that point. And when you have your coronal slices, that again shows that basal distribution really beautifully. So this is a peripheral basal predominant fibrosis in another case of typical UIP. So this table comes from a paper that was published in 2018, which is the Fleischner Society Consensus Guideline for the Diagnostic Criteria for IPF. So this is a multidisciplinary paper that looks at the clinical criteria, the histopathological criteria, and of course the radiological criteria. And this is the table of features for the radiological diagnosis. So this feels like it's going to contain a lot of information, but I don't want you to worry. I really just want you to focus on these two words, typical and probable. And the rest of it's all going to fall into place. UIP on radiology requires this basal peripheral distribution of fibrosis that we've just seen. typical UIP pattern fibrosis has honeycombing, probable UIP pattern has no honeycombing. And again, remembering the significant prognostic implication of honeycombing, this is a key differentiator to make. Typical UIP is associated with a 100% histopathological correlation with UIP on open lung biopsy. Probable UIP has a very high association, also somewhere in the order of 95%. So these are both patients that we expect to have UIP pattern on histopathology, but we're differentiating a significantly separate group of patients prognostically. Let's have a look at what probable UIP looks like. And here's a case with just mild extent disease. You can see as we come down this beginnings of this fine reticulation in the subpleural lung, and as we scroll all the way down to the bases, we're going down to that money shot to look in the costophrenic angles. And sure enough, as we get to those last slices, we can see those excess reticulations down in the costophrenic angles where we need them to be for this diagnosis. Minimal traction bronchiectasis with just a little faintly dilated airway here in the lingula, and a mild extent probable UIP pattern. Let's just have a look on the coronal images to confirm that basal predominance. You can see that the lung apices are relatively clean, and then as you come down, we fill up those costophrenic angles. Another case, similar sort of pattern, a little bit more established coarseness in the right upper lobe here, where we've got a little bit more in the way of that traction bronchiectasis, but still the predominant abnormality here is that fine reticulation. It's in the periphery of the lung. We want to test that center core and just have a look through that as we scroll down through the stack. And again, you can see just how beautifully clean those bronchovascular bundles are as we come down. So again, the money shot down in the costophrenic angles, and notice the way that this fine reticulation is really swept up to the boundaries of the pleura. Probable UIP pattern fibrosis. Traps in the evaluation of a UIP pattern on radiology center around the interpretation of honeycombing. So here is a case where we've got clustered subpleural cystic spaces, but you're probably all going to be pretty comfortable that there is lung interspersed between these cysts. And in fact, what we're seeing here is post-inflammatory bronchiectasis, quite severe in this particular patient with no fibrotic lung disease. And this is a reasonably obvious example, but the same principle applies when assessing patients with severe traction bronchiectasis in terms of the ability to mimic honeycombing, because, of course, a dilated airway and cross-section is going to have the appearance of an isolated cyst. And this highlights the importance of interrogating the multiplanary formats to really scrutinize whether what we're seeing is traction bronchiectasis versus honeycombing because of that prognostic significance. Perhaps a more nuanced differentiation here in a case where, again, we've got these clustered subpleural cystic spaces, and the temptation is to package this up as honeycombing and a UIP pattern fibrosis, but let's have a look at the whole study. So if we start up at the apices, we've got this scattered small volume centrilobular emphysema and what is clearly paraseptal emphysema when we're actually looking up at the top of the lungs here. So we've got these subpleural lucencies, but they have no definable wall. As we scroll back down to where we started, you can appreciate the way that there is peripheral thickening associated with these subpleural cysts. And then the question is, how do we start differentiating this from honeycombing? This is not honeycombing. This is all paraseptal emphysema. And the clues here in the interpretation are, of course, the presence of the background obvious emphysematous change, but the degree of wall thickening in these subpleural cystic spaces is less than what we saw in those cases of typical UIP pattern that we started with. And also the size of these cysts is very variable. So here you've got one that's probably a good 15, 16 millimeters, another one next door that's about 12 millimeters, and we come down to one that's about 5 or 6 millimeters. So there's real variability in size, which is typical for paraseptal emphysema, and coupled with those other features comes together for a diagnosis of emphysema with superimposed scarring. So this is a localized scarring process. This is local fibrosis rather than a diffuse fibrotic lung disease. Emphysema with scarring. So when we're interpreting UIP pattern fibrosis, we're thinking of these mimics of honeycombing to allow a precise application of this terminology. The final thought before we move on from UIP is the use of the term idiopathic pulmonary fibrosis, which is not for the radiologist to use. This is for the clinician to use when they've excluded other etiologies of fibrosis, whether the patient has rheumatoid arthritis or they've been on some kind of pneumotoxic medication. They make the diagnosis of exclusion clinically of potentially an idiopathic pulmonary fibrosis. We restrict ourselves to the term UIP, usually interstitial pneumonia, which aligns itself to what the pathologist is calling on their interpretation in the setting of lung biopsy. And that's the principle behind terminology in reporting radiologically these diseases. So moving on to the second in the triad of fibrotic lung disease, what we used to call chronic hypersensitivity pneumonitis, what we now call fibrotic hypersensitivity pneumonitis. And again, that's acknowledging the alignment with histopathology, where this disease exists on a spectrum from a pure inflammatory manifestation in that kind of acute subacute form over to a fibrotic predominant form, and acknowledging that timeline is variable in different patients. This paper that was published in 2020 is an international clinical practice guideline that establishes the requirements for a diagnosis for hypersensitivity pneumonitis. And again, this is multidisciplinary with clinical criteria, histopathological criteria, and of course, radiological criteria. And radiologically, we require these two criteria to be satisfied. We need an evidence of some kind of airways involvement to the process, which is the correlation of the fact that hypersensitivity pneumonitis is the result of usually exposure to inhaled organic antigens. So the pathophysiology of this disease is centered around the small airways, and that manifests radiologically, and also a concordant compatible pattern of fibrosis. So with airways involvement, we can see those little fluffy centrilobular ground glass nodules that we associate with old term subacute hypersensitivity pneumonitis, but actually commonly it's air trapping. So these little lucent lobules of abnormally lucent lung that we see in these cases. The concordant pattern of fibrosis as defined in that paper is termed as axially diffuse. So in the axial plane, diffuse across the cross-sectional area of the lung. But what does that actually mean? That just means that in those cases with UIP, when we were looking at that center core of the lung, is not going to be clean the way it was in those cases. There's going to be a peribronchovascular component. So we're looking for fibrosis and lung parenchymal abnormality that's nestled in those bronchovascular structures and filling up that center core of the lung. The other feature that we see radiologically is the 3-density appearance, meaning black lung, air trapping, lucent lobules, grey lung, normal, and white lung, ground glass opacity, what we used to call head cheese, which is a very highly specific feature for hypersensitivity pneumonitis when we do see it. So we look for it specifically, and we liberally apply the use of expiratory imaging to try and demonstrate that, to really try and swing the needle towards this differential diagnosis when we have other features that are suggestive. So let's have a look at how these principles come together for a diagnosis of fibrotic HP. And here we have a case of severe extent disease. So separating again the morphology and the distribution. The morphological characteristics here are of fine and coarse reticulation. We've got traction bronchiectasis, which is reasonably extensive and comes back quite centrally. We've got a bit of ground glass superimposed, and in the subpleural lung, we even have confluent fibrosis with these irregular consolidative foci in the lung periphery. Other features are mosaic attenuation, in that there is a variable density between different regions of lung parenchyma. So we've got some lucency, some sort of more mid-opacity regions of lung, and we want to investigate those with expiratory imaging. So this is the expiratory study. You can see the flattening of the posterior tracheal wall, demonstrating that this has been performed in the expiratory phase. And as we come down through the lung parenchyma and get down to the bases, you can see a really beautiful demonstration of that 3-density appearance. So here we have lucent lung, this lovely secondary pulmonary lobule that's outlined in black with air trapping. We've got the normal grey lung, and then we've got that white ground glass opacity. So 3-density appearance. We're ticking the box with airways evidence in the criteria for the diagnosis of HP, we're seeing this 3-density appearance, which we know is highly specific. We want to examine in more detail the distribution of this disease. And as we scroll back up and down through the stack and concentrate on that center core of the lung, you can see how all of those bronchovascular structures are surrounded by abnormal lung. So there's really very few bronchovascular bundles that have completely normal lung around them. So there's a pronounced bronchovascular component to this fibrosis. So we've got airways evidence, we've got the concordant pattern of fibrosis, and this is a confident diagnosis, typical fibrotic hypersensitivity pneumonitis. If you just look at the coronal images here, the coronal distribution shows there is a very mild upper zone predominance. Okay, so there's still abnormality at the lung bases, but actually in the upper zones, there's just that little bit more. Now, the teaching that we all remember is that hypersensitivity pneumonitis is an upper zone predominant fibrosis. But while that is very true, that pure upper zone distribution is actually really uncommon. It's seen in only about 10% of cases of HP, and it's not reliable for the differentiator. So we're concentrating on this airways evidence and the peribronchovascular distribution of fibrosis, knowing that if we're lucky and we see the upper zone predominance, that's fine, but that it's not necessary. And in fact, many cases are lower zone in predominance. Let's have a look at a couple more cases to just have a look at the sort of varied manifestations of this disease. Because when you sort of first scroll through this, you at sort of first glance get this impression that it's quite a different appearance to what we saw on the previous case. And it is in terms of the morphological characteristics, because there's actually quite a lot of ground glass here. Yes, there's a little bit of traction bronchiectasis with these little peripheral dilated airways and nice demonstration of some airway irregularity, but we don't have that same kind of coarseness that we saw in the previous case. So the morphology is different. But when we interrogate for distribution and we look at that center core of the lung, it's clearly abnormal throughout. And this is a very strong peribronchovascular predominance in the distribution of this particular interstitial lung disease. Now, I'm thinking about those two criteria that we need to satisfy, and I want to assess for any airways evidence. So we go to the expiratory imaging, and as we scroll down through this, we can see these few scattered little lucent areas which add to that diagnostic confidence that this is fibrotic hypersensitivity pneumonitis. Have a look on the coronals. This is a basal predominant disease. That doesn't worry us at all. So another case of fibrotic HP. One more case just to seal the deal. Again, coming down, this is severe extent disease. There's this diffuse, extensive background ground glass opacity and very coarse reticulation with traction bronchiectasis that is really quite severe as we come right down, and profound in that inferior lingual lobe with a lot of lower lobe volume loss here. And this is a much more coarse example of fibrosis than the middle case that we saw. On the expiratory imaging, a few of these scattered areas of air trapping to tick the box for airways involvement. Clearly a peribronchovascular component to the fibrosis again, and both criteria ticked for hypersensitivity pneumonitis, another example of a very basal predominant fibrotic HP. Traps in the interpretation of fibrotic hypersensitivity pneumonitis in part revolve around its differentiation from UIP. So we're really used to fixating on honeycombing as we have here in the middle lobe and going straight to a diagnosis of typical UIP, but we have to always go back and remember that the morphology is one part of the interpretation and the distribution is the other part of the interpretation. So let's have a look at this entire case. So we've got selected slices here from a very end-stage fibrotic process. We've got extensive honeycombing, we've got severe traction bronchiectasis. We can see that real rippling of that airway as it comes through here in the middle lobe, and severe extent disease. But when we get down to the bases, the costophrenic angles are in fact more normal than elsewhere. And as we go back up through the stack, looking at that center core of the lung, there is really extensive disease. So there's a strong peribronchovascular component. And in fact, this is an upper zone predominant disease. This is fibrotic hypersensitivity pneumonitis. So another case where we come down to that distribution to really seal the deal and work out which way we're going in our differential diagnosis. So a patient with moderate extent disease, we've got traction bronchiectasis, we've got fine reticulation, and really nothing in the way of honeycombing. Now we look at that distribution and we're trying to assess that center core of the lung. And as we look here, we've got disease that really fills that entire axial slice. So remembering that the criteria for hypersensitivity pneumonitis required this diffuse axial distribution, we're wondering if that's what we're dealing with here. Let's try and scroll up the rest of the case. We've got some clean bronchovascular structures here, but then these bronchovascular structures are surrounded by abnormal lungs. So is this one, and we need to make the call. So what I want to point out here with this case, which is a case of UIP pattern fibrosis, is that when we assess the lung periphery, we're not just talking about the lateral periphery of the thoracic cage, we're talking about the circumferential periphery of each lung. So that means that we've got abnormality laterally, but we can have fibrosis along the mediastinal pleura. That is not a problem. When we get down to this slice down at the lung base and look at this distribution of disease, you have to remember that on the very next slice, we're seeing diaphragm already. So we're actually just cutting on this slice through the inferior lung periphery. And when we go up that center core, which is truly that very center component of each lung, that's where we see normal vessels, and that's where we see that this is a peripheral predominant disease. So this is a patient with UIP. So when we're assessing the fibrotic hypersensitivity pneumonitis distribution, we're remembering that morphologically, not all honeycombing is UIP. It's completely fine to have honeycombing in HP, and we're remembering the distribution of the lung periphery rather than just the lateral margins of the thoracic cage. So the final disease in the triad of fibrotic lung disease is NSIP, again, peripheral and basal in distribution, but now with subpleural sparing. So remember that probable UIP where we see that fine reticulation swept up to the pleura. In NSIP, we see the maximal intensity of fibrosis just back from the pleura. So you've got involved lung and then more normal lung immediately deep to that pleural margin. That's what we see in patients with mild and moderate extent disease. You can imagine that as this goes on and the extent of abnormality increases with time, you end up spilling over that subpleural sparing. You get disease right out towards the pleura. And that's when you're looking at other morphological features that we will have a look at, other nuances in the distribution of NSIP. But also you're going back in time and finding that KUB from 8 years ago, which showed the bottom of the lung bases and just caught that little bit of early fine reticulation with subpleural sparing that seals the deal. So the other feature that we have been taught to associate with NSIP is ground glass. And it's important to appreciate that the strict definition of the ground glass in NSIP is that of a ground glass infiltrate that is distant from established features of fibrosis. What this means is that if you have ground glass that is superimposed on reticulation, on traction bronchiectasis, the interpretation radiologically is that this is actually fine fibrosis that is below the resolution of CT and that is manifested as partial voluming and a ground glass opacity, but does not represent true, by definition, ground glass, which implies a cellular infiltrate that has potential for reversibility with immune suppression. So it's a clinically significant differentiator. Let's have a look at a couple of cases and think through this a little bit more. So here's some selected cases of a patient with connective tissue disease and NSIP, and we see fine reticulation with a little bit of faint traction bronchiectasis here. As we come down lower, we see that fine reticulation interspersed with more coarse reticulation and established traction bronchiectasis. So this disease is maximal back from the pleura. You can see that that immediate subpleural lung is spared, and this grey density that is superimposed on all of these features of fibrosis is interpreted as fine fibrosis below the resolution of CT. So another case, again, of NSIP pattern fibrosis, And this is different in that there is far less traction bronchiectasis. There's just a couple of scattered tiny little airways that are just a little bit dilated out towards the lung periphery, but the majority of the infiltrate is a fine reticulation. And in this case, there actually is ground glass that is away from established features of definite fibrosis. There's quite a lot of it. And the interpretation here, radiologically and important to the clinician, is that this would be reversible with immune suppression. Let's just go down through the slices again. And when you scroll quickly through, you can really appreciate that beautiful subpleural sparing. The other feature that I want to dwell on in the setting of NSIP is that the abnormal lung tends to be contiguous. It doesn't have those sort of skipped areas where you've got some involvement and then completely normal region, and then next bit around the periphery is abnormal again. It's really contiguous. So this contiguity is really typical for NSIP, and the other feature that's really typical for NSIP is that the degree of coarseness is homogeneous throughout. So everywhere where you see abnormal lung, it is similarly coarse. So really fine reticulation everywhere, blending into a little bit of ground glass opacity, but we don't have that same bit of fine reticulation, total honeycombing that we did in the UIP pattern fibrosis. So NSIP. Traps in the interpretation of NSIP are at base the accurate interpretation of the presence and extent of this disease, because NSIP is much more slow moving than UIP. It's really often present in very small volume, and an accurate appreciation of how much disease you have and whether you have any disease at all is a big part of the workup. And this is where prone imaging becomes absolutely critical to the investigation of the patient. So here we have a patient with some peripheral density in the posterior lungs, and when we scroll down, it's all subpleural. Is there a little bit of sparing? Is there some scattered reticulations within this as we get right down? This is the typical features of microatelectasis, physiological dependent change, and I'm sure most of you would be pretty comfortable with that. There's a few features that are quite typical. This meniscus, where it really just fills that sort of crescentic posterior lung, and the relatively high density appearance is all typical for atelectasis. And in fact, this patient had a CT a few days earlier that shows that the lung parenchyma is normal. Okay, so here's another patient where it becomes just a little bit more challenging. We've got this graduating increased density layered against the oblique fissure, which is what we typically see with atelectasis. But then as we come down to the base, there's a bit more patchy ground glass opacity that's not quite laid in that typical meniscus. It's got a little bit of heterogeneity to it. Is there any reticulation superimposed on that? At this point, this is just a supine inspiratory study, and the workup for ILD is incomplete. We have no idea what's going on here. But when we turn the patient prone and improve the aeration of those posterior lungs, you can see the vast majority of these changes completely resolve. You've got some residual bands of atelectasis, but a lot of that patchy ground glass has completely disappeared, but importantly, not all. So here we still have this peripheral fine reticulation with subpleural sparing. You've got the maximal intensity of reticulation back from the pleural edge, and there is real residual fibrotic abnormality in this case. So this is the critical importance of prone imaging, and I have a very low threshold for calling these patients back when they've been imaged and have not been reviewed on the table when they have these kind of appearances, because until we have this adequate aeration of the posterior lungs, we haven't worked this patient up. All right. I want to talk just a little bit more about ground glass opacity. We've talked about fine fibrosis below the resolution of CT. I want to just go through one illustrative case here where we've got extensive ground glass superimposed on clear, obvious background fibrosis. And there's really an enormous volume of ground glass opacity here. So it's really filling up these lungs. It does coexist with the coarse reticulation and traction bronchiectasis down towards the bases, but there's plenty of ground glass proper elsewhere. And I think there's a great temptation to call these cases with this huge volume ground glass NSIP because we really have this keyword association between the two diseases. But come and look up at the upper zones here and you'll see a few features. Number one, let's just talk about the morphology here. We've got some fine reticulation, we've got elsewhere some traction bronchiectasis, and we've got some early honeycombing anteriorly in that left upper lobe. Notice that the degree of coarseness is heterogeneous in the variously involved lung, where you've got just fine reticulation, and you've got some early honeycombing, and you've got a patchy distribution where you've got bits of lung that come right up to the pleura and completely normal. So this appearance in that least involved lung is raising a flag for a UIP pattern fibrosis. And in fact, when we go on to this patient and review their previous imaging, we've got a CT from several months ago before they underwent a precipitous decline, where we see fine reticulation in a peripheral distribution. We've got completely clean center core of the lung. And as we get down into the costophrenic angles, we've got filling of the costophrenic angle with more of that fine reticulation, a few scattered foci of traction bronchiectasis. And at this time, this was a probable UIP pattern fibrosis in a patient who has UIP radiology and has gone on to have an acute exacerbation. Acute exacerbations of fibrotic lung disease carry a tremendously miserable prognosis. There's only a 50% survival in IPF, and the baseline of survivors is significantly lower than before the exacerbation. So this is a clinically pretty dismal complication of fibrotic lung disease. So when we're interpreting NSIP cases, we are thinking of that critical importance of prone imaging to accurately assess the presence and extent of disease, and we are decoupling that concept of ground glass opacity from an automatic association with NSIP and appreciating the role that it has in each of these three entities. So as acute exacerbation in UIP, as part of that really highly specific 3-density appearance in fibrotic HP, and as either fine fibrosis below the resolution of CT when it's superimposed on fibrosis, or as a true cellular and likely reversible infiltrate when separate in the setting of NSIP. So let's go back to this table. The diagnostic criteria for the radiological interpretation of UIP, because I think you're ready for it, and we're going to fill the rest of it in. We'll go to the end, we'll look at the non-IPF category, and I said we can't use the term idiopathic pulmonary fibrosis, but what we can do is tell the clinicians when they're not allowed to use it either, and that's when we have any of these features that point to a final diagnosis that is not going to include the possibility of IPF, meaning that it's not going to be a typical or probable UIP pattern, and that is upper and mid-zone predominance in those rare cases of HP that actually demonstrate that distribution, the peribronchovascular component of fibrosis in HP, in NSIP, the subpleural sparing, the chronic ground glass opacity, so non-acute, meaning the ground glass that we see in either HP in the 3-density appearance or in NSIP. Air trapping, HP, nodules, now we're talking about sarcoid consolidation, now we're talking about organizing pneumonia, cysts and cystic lung disease. Any of these features, if they are present to a significant extent, is a non-IPF category of fibrosis. And the final column is merely those unfortunate occasional cases that fall between the cracks, and the term we use for that is inconspicuous non-UIP features. So yes, you're mainly peripheral, maybe you're mainly basal, but you've got just a little bit of something from that last column which gives you a truly indeterminate pattern of fibrotic lung disease. But all I actually want you to care about and to remember is that typical UIP has honeycombing, probable UIP does not. So how do we actually go on to report these cases? Well, we need to have in mind as we approach the imaging those features on the imaging that would be predisposing factors for fibrosis, anything that might mask the clinical interpretation of the disease, and obviously potential complications. So there's a strong association between gastroesophageal reflux and idiopathic pulmonary fibrosis. That's important to appreciate. The masking comorbidities radiologically are the presence of emphysema, because if a patient undergoes spirometry with both emphysema and a fibrotic lung disease, the restrictive abnormality relating to the fibrosis coupled with the obstructive abnormality relating to the small airways disease, merge together and falsely normalize the spirometry results. The clue in interpreting lung function testing is the performing of an additional test of the diffusion capacity, which is not necessarily done automatically, which shows the disproportionate reduction in DLCO that we see in these cases. So the clinician knowing that there's emphysema coexisting is important for them to be able to interpret the lung function testing. Complicating factors, we all know that the WHO class 3 pulmonary hypertension category is reserved for patients with abnormal lung parenchyma. Pulmonary hypertension is a complicator, and the presence of fibrotic lung disease itself is an independent risk factor for lung cancer. So our report is going to cover the distribution of disease, that coronal distribution and axial distribution, and of course an assessment of the different morphological features that make up the lung disease. When we look at the rest of the lungs, we are reporting the presence and extent of emphysema and any nodules and masses. And when we're looking at the mediastinum, reporting the size of the pulmonary artery, remembering that 30 millimeters is that upper limit of normal, and assessing for the presence of a hiatus hernia. So the conclusion would therefore read something like moderate extent fibrotic lung disease, radiological pattern, probable usual interstitial pneumonia. And then importantly, there has been mild progression over the last 8 years. Because we've gone and opened up that KUB from 8 years ago and had a look at the lung bases where there was that trivial reticulation, which wasn't reported on at the time, but is clearly the initial stage of what we're seeing now. And that feels like an assessment of something that's way out of the sort of realm of clinical relevance. But in fact, it's absolutely critical because these patients have access to antifibrotic therapy, which arrests the decline of their disease. UIP has a very poor survival rate. These patients should access antifibrotic therapy early to prevent that rapid decline, but the treatment has significant morbidity associated with it with a poor side effect profile. So there's a real equipoise of when to actually go in and begin this treatment or when to keep watching. Knowing that the disease is moving slowly over a long period of time is critical information for the clinician, who could then afford to hold off and do annual surveillance to wait for that radiological trajectory to increase more rapidly before instituting treatment. So that kind of long-term assessment is really important. Let's go back to this scenario of very low volume disease. And I think we used to all dismiss these as probably age-related changes. And what we know now is that low volume disease in the asymptomatic population can be profoundly clinically significant. The term for this is an interstitial lung abnormality. So we are talking about asymptomatic patients who have more than 5% of the lung volume by visual estimate involved in an interstitial abnormality of some kind. And what we know from these large lung cancer screening trials, where we have lots of longitudinal data on these patients, is that patients who have an abnormality that conforms to typical or probable UIP pattern will all universally progress over 5 years. And this is not just some kind of idle radiological curiosity, but in fact, it is a marker for an abnormal response of the lung parenchyma to insult. So what we see in these patients is that in the setting of, for example, admission to ICU for sepsis, all comers have a risk of ARDS of about 15%, and that risk increases by 5-fold if you have a pre-existing ILA on your chest CT. So there's important clinical implications of this and what these patients require. If they have abnormality that meets the criteria for an ILA, is a referral to a respiratory physician, baseline spirometry, ongoing follow-up, and assessment for ILD risk factors. So what does an ILA look like? It looks like this. We've got a patient here with just these scattered, intermittent, fine reticulations. You can see how sparse they are. They're more than a centimetre apart. They're really just a few scattered reticulations all in the periphery of the lung. The center core of the lung is normal. When we come down to the lung bases, we've got that money shot of the costophrenic angles with the excess reticulation. So this is a probable UIP pattern, ILA, interstitial lung abnormality. What is not an ILA? This is not an ILA. So this fine reticulation, subpleural line adjacent to bulky thoracic osteophytes, very common in the azygoesophageal recess. This is related to local shear forces on the lung parenchyma, mechanical reaction with local scarring, not a diffuse fibrotic process. Good. How are you feeling? You're feeling good because we've looked at this kind of approach to the interpretation of fibrotic lung disease. We're looking at those morphological features. We're also looking at the distribution and thinking about the core of the lung and the periphery of the lung. We're looking at UIP, differentiating typical from probable by the presence of honeycombing. We're talking about fibrotic hypersensitivity pneumonitis and the two essential criteria that we need to satisfy, which is commonly seen as air trapping and this peribronchovascular component to the fibrosis. We've talked about NSIP, subpleural sparing in the early course of the disease, and the importance of prone imaging and looking back at the old studies to see where the disease came from. And we've decoupled that concept of ground glass opacity automatically meaning NSIP and looked at the way that this entity manifests in all three of these diseases. So well done. With these principles in mind, you can go forward and start reporting these cases with confidence. Thank you for listening.
Well, that was another fantastic lecture by Miranda, and you'll be able to catch Miranda again at Radiopedia 2023 with a brand new lecture which is titled Tumour versus Infection, Focal Opacities. And that's one of 5 new chest radiology talks that we've got at the conference, alongside 2 encore talks. And if you really love chest imaging, don't forget that we'll also have a session showcasing the very best R posters on a chest radiology theme. But that is all for today. We'll be back in 2 weeks with actually our very last live stream before the conference itself. So I do hope to see lots of you there. Bye for now.